as an infectious disease epidemiologist, I find infectious diseases fascinating. I've been working in infectious disease for 30 years, and they're very interesting. And so having the opportunity to work with a new disease, in some ways was a great opportunity professionally. Not that I wanted it to happen at any way, shape, or form. And really, actually, the experience of it was hell. It was hell.
Welcome to Life Became Very Blurry, a podcast from the Vermont Historical Society, sharing the experiences of Vermonters during the COVID-19 pandemic. I'm Amanda Gustin, Director of Collections and Access at the Vermont Historical Society. Over the last 3 years, I've led a team to collect the history of COVID-19 through oral histories, archival material, objects, and more. We know that we're just getting started, but for the 5-year anniversary of the start of lockdowns, we've put together excerpts from oral histories that offer a look back. What was it like to be a Vermont healthcare provider during a global pandemic? In this episode, we hear from a cross-section of doctors, nurses, epidemiologists, lab workers, and others on the front line of the state's medical response to COVID-19.
So being an infectious disease specialist, I had some idea of what was going to happen. Obviously it was a new disease, and there were many, many details about it that I could not have predicted and didn't know, but I did have a general idea of, what an epidemic and a pandemic was going to look like. And it was almost like waiting for a tidal wave to come. We knew what was happening in China and other countries, and we could kind of see it coming. We had the first cases out west, and then it was, creeping towards Vermont. And we knew we would have a case. We knew we'd have many cases. And we're just waiting for this tidal wave. And we were doing all kinds of things to get ready. We were putting many things in place. We were talking constantly. We had incident command up and running before we had our first case. This was at the hospital. And when we had our first case, it was like that, that tidal wave hitting. And although it was a little bit, at first, it was sort of like the big part of the tidal wave, but then it was just a continuous tidal wave. It wasn't like a one time, there's a tidal wave and now the water recedes. It continued to be like a fire hose for a full year and really 2 years into it. We were, of course, very busy in infection prevention. And it was very challenging because there were, someone at the hospital, when the vice president said, we're building the plane as we fly it. And it really was like that. We had our expertise. We had, information from the CDC and from the state health department that we use to make decisions and make policies and protocols. But it seemed like there was always some new iteration or something new. For one thing, the guidelines kept changing. And so one of our jobs was to take the guidelines that were coming out from CDC and the state health department and then interpret those for our own facilities. So putting them into actual protocols and policies, making decisions about who was going to do what. We were writing those up, and people wanted them, they needed them. And so the phone was constantly ringing, people asking, what should we do about this situation? What should we do about that? And we'd be literally working on them at that moment, but the phone was ringing so much that we couldn't get them done. So that was a challenge. The phone was ringing constantly. At that time, let's see, there were five of us in the department, and it was all we were doing. One thing we found was that it was very hard to anticipate everything. And even if we sort of could, it was hard to figure out what we were going to do. There were so many decisions to make. And we were just trying to keep our heads above water. And we would sometimes, I remember asking, well, what are we going to do if X happens? And we would all stare at each other and just say, well, we'll figure it out when it happens. And that may seem like, gosh, we weren't really preparing well, but it was the kind of thing where we literally couldn't fathom. It was just too overwhelming to just keep up with what was actually at our door, on our doorstep.
I'm a pediatric nurse practitioner, and I was doing that work in March of 2020, and I'm currently a school nurse and have also continued to work with COVID patients since March of 2020. When it started, it was pretty scary. We didn't know anything about how we should manage the practice. So there was initially no instruction on, could we see patients indoors? Could we see sick patients? If we had sick patients, should we see them outside? We just didn't know how to set up the practice. So as quickly as information was available, we got guidance from the Vermont Department of Health. But initially, we set up plastic shower curtains to decrease any chance of air circulation back where the secretary sat. We designated one exam room where Dr. Miller and I would go in and out once we've seen a sick patient out in the parking lot. We did not bring any sick kids into the office at that time. We saw them all outside. Even if we thought it's probably just an ear infection, we would still go out to the parking lot and see them outside. The waiting room was immediately closed. So we set up a system where when somebody would get to the parking lot, they would call in if it was a well visit. We had one room designated for well visits. And initially we just had one, and then we got it worked so we could have 2 rooms for well visits. That was a little further on. Initially there were other things that we had to figure out too, like kids with respiratory problems. We had to figure out whether or not we were going to see them at all. But then we figured out a system where we could run the extension cords. We could run from the office all the way to the parking lot if a kid needed like an albuterol treatment or something like that. So we worked out systems to make the parking lot work. We had a tub where we could have all our equipment that we needed to take outside, our otoscope and anything else, our thermometer. We had a stethoscope that we used for seeing sick kids outside. So we had a way to carry that all outside, and we just put it on the hood of the car, and we just used what we needed as we went.
So the kids stayed in the car?
Yes, the kids stayed in the car, and it was really hard to do a proper exam with the kids in the car. The little toddlers, like if they had an earache, they were already, in a lot of pain anyways. So, we'd see them either sitting on their parent's lap or in the car seat. Sometimes the parent, if it was a pickup truck, they'd sit on the gate of the pickup truck would be down, and the parent would hold the child on their lap, and we did our regular exam, checking eyes, nose, throat, ears, listening to lungs, checking their abdomen, but it was much more difficult than when they were in an exam room. Initially, our biggest problem initially was we didn't have enough tests. So, I saw a couple kids. I saw somebody probably about the 3rd week in March that probably did have COVID, but I didn't have any way to test her. I saw another kid in April outside. She probably had COVID. I didn't have any way to test her. So the testing was a big challenge.
The way that the CDC and our laboratory is set up is that if there is a novel virus, at least this is how it has been, it may change. The CDC works with the public health laboratories in the state to get them the CDC approved assay, which allows those public health laboratories to test for that virus. They develop basically the testing mechanism, formula for testing those specimens, and they go to the public health laboratories first. That's not to say UVMMC and especially was looking pretty early on at getting their testing up and running, but this was a novel virus. No one had ever seen it before. So we were for a series of about 2 to 3 months. We were the only laboratory in the state that was testing for COVID. One of the biggest challenges for us was the uncertainty. We'd never encountered anything like this before. So it was hard to know what the playbook was to pick up and run with, because we were just sort of making it as we went along. In the beginning of the pandemic, so in March, we were getting samples primarily from the hospitals, and they were coming to us through the statewide courier service that we have, and then also through the hospital courier system. Later, into this May, June, July, summer months, we were working with the National Guard to set up pop-up testing sites all over Vermont so that the public could come and get tested. And then those specimens would arrive in huge coolers, and we would test, thousands a week. So we went in this laboratory from testing 25 specimens per day to a daily volume of 1,600 by the middle of the summer. And those specimens in the beginning would come in these little vials with a plastic cap, and somebody has to turn that plastic cap with their fingers and their wrist and their hand to open it and then prep it for testing. And we pretty soon, within those first couple of months, saw people having overuse injuries. So we did a couple of things. We brought in ergonomics. We did an ergonomics assessment with a company that contracts with the state of Vermont to come in and look at how people were standing and sitting and the motions they were using, and make recommendations. And then we also reached out to an entity called in Burlington, the city of Burlington, called the Makers Space, which is basically a group of craftspeople, engineers, and asked them if they would come in and look at our instruments and tell us if there were some things was there something they could make for us that would automate that motion of twisting. Mm-hmm. And we ended up with sort of a hybrid solution, which was we ordered a decapper from a laboratory company called Thermo Fisher, I think it was. But the decapper wasn't gripping the cap enough to get it off in as quick succession as we needed. And so the Makerspace came in and they looked at it, and they actually took the whole instrument away and came up with a couple of different type rubbers and materials to really grasp that specimen vial, and came back to us and with a solution, and that really helped. So the staff just put the vial into the decapper, and the rubber material sort of conformed around that the Makerspace created, conformed around the vial, and it twisted it off for them, and then they could just take the specimen. So they didn't have to do that twisting motion anymore. There was still stress and strain on backs and sitting. Our staff worked incredibly long hours, especially in those first several months.
In the beginning, at the end of 2019, I was working full-time at the VA hospital in White River Junction, and we went into preparation mode. So as soon as it started coming up and we were seeing what was happening in Italy, we canceled all the surgeries. We shut down most of the clinics except for urgent or semi-urgent stuff. And we just kind of went into prep mode, essentially. The hospital was as it turns out, remarkably quiet. We did end up having the first death in Vermont occurred in our ICU from COVID. But it was a gentleman who was in his late 90s and, was in fragile health otherwise. Very subtle start to the pandemic. That carried for a while. And then I believe it was the Delta variant came around and we became very busy with COVID cases. We saw many more deaths during Delta, the Delta variant, and sort of got a taste what the rest of the world or the rest of our country felt during what I feel was the first wave. There was a lot of guidance that came from our infection prevention and infectious disease people that it was ever changing. And instead of kind of giving us the why, it was just saying, this is the way things are now. Now you have to, if you get sick, you have to, or if a patient's sick, they have to quarantine or be on isolation for 10 days. And then it was 14 days. And then it was 7 days. And it was just this constant evolution of guidelines. And it became like, we almost were like, well, this is kind of a joke. Like, it doesn't seem like there's a unified brain coming up with this. It's just, the guideline du jour. So it weakened them for the frontline staff because they were so ever changing that we didn't hold any stock in any of it. It was sort of like the boy who cried wolf type scenario. Support was, on the other hand, we felt supported, especially at the VA. And again, like I said before, I did a travel assignment during that time to help Central Vermont Medical Center in Berlin, Vermont, which was there was a great contrast in the two facilities. But in the VA, I think we felt well supported. We felt listened to. We just sometimes were frustrated by the changing guidance. It just was a scary time, and it was, and we were proud, I would say, to be able to make a difference and to be kind of the frontline people during this major world event that touched everyone.
I live in Norwich, Vermont, and I want to share my experience as a nurse practitioner working in a clinic that offered care to homeless and uninsured individuals, adults in the Upper Valley. Maybe March 2020, when we started, even before then in February, started getting an inkling that things were not looking very good on an infectious disease front. And I have a background in public health, and that raised my concern fairly early on, maybe back in January, especially for the population I cared for, because they were either homeless or didn't have health insurance, very marginalized, very fragile population. And my mind went immediately to, how is this going to work out if there is indeed, a public health emergency? This is a nonprofit, and a nonprofit that is staffed mostly by volunteer physicians, nurse practitioners, and physician assistant. I was the one employee salaried employee, and there was one of our salaried employees. There were two of us. Our patient volume could go up to 600 visits a month. And there was obviously a huge concern for our volunteers that were older and possibly more vulnerable to getting the virus and becoming quite ill and even dying from it. We were watching what was going on in New York, and it was exceedingly concerning. So we decided to just close the clinic, but to maintain services remotely. It was a struggle because our patients did not, for the most part, have cell phones. These are folks that don't have resources. So trying to get a hold of them to offer any sort of care and make sure their medications are refilled or any of that was very challenging. But we did what we could, and we were able, my goal was to keep people out of the emergency room and to keep people hopefully COVID free. And we were able to do that for the most part. With, again, a lot of visits to encampments and motels, trying to get people like cell phones, even was like these, burner phones, so we can, and the state gave us money for this, so we can, reach out to them, make sure the medications are refilled and any maintenance drugs, chronic conditions were cared for. So that was my focus. That took a lot of time. And then, of course, nothing else went away. So everybody still had diabetes and high blood pressure and, addiction, a lot of addiction issues, psychiatric problems were rampant, psychosis and depression. And all that was accentuated, by the way, by isolation. So, all these problems seemed to be more for these folks. So that was a lot of work. So we were pulling like 60-hour weeks, easy. We were fortunate that the state was able to give us full PPE pretty early on. They realizing that this was what we needed to take care of these folks. We certainly didn't have the money to buy PPE because it was exorbitant and hard to find. So yes, I was in full PPE. I usually went with a police officer and a social worker. That's how we did it at first. And eventually, because there was a trust that developed between myself and they came to know me, I felt comfortable going by myself. The encampments actually disappeared pretty quickly because they didn't want people out. The state did not want people out in, these encampments. So they moved them to motels, mostly in White River Junction area. So I was able to, I wouldn't go in the rooms, they would come out to me. So my car essentially became like an exam room. The back I did blood pressures and, blood sugar checks and listened to heart and lungs and did, wound care in the parking lot. So that became where we cared for people. Preventative care was not really part of the picture. Now for this population, preventative care is really difficult because without insurance, you can't really have preventative care unless you have to pay out of pocket. During COVID, it was really whittled down to trying to keep everybody out of the emergency room, keeping them COVID free, getting vaccinated, it was like treading water, crisis management. I mean, that's what I just crisis management. We saw an increase in domestic violence during that period. So it kind of bled into like the family structure, bled into the mental health status of our adult patient, the stress. These people were already kind of starting off with a baseline that wasn't great. So this was just kind of sent them into a tailspin. So it was a lot of intervention and not a lot of resources. On a good day, there's not a lot of resources for mental health. So that was very, very difficult. And I'm not a psychiatrist. I'm not a mental health provider. So it became kind of having to do what I could with the resources I had, which were not a lot. So it was very hard. That went on and on, it seems, until I'd say things started calming down about 2022, late 2022, when we're able to kind of feel like we were in a better place where our older volunteers were willing to come back. They were vaccinated. We were still masked, but that's okay. We were able to see folks in the clinic, which is so much better than trying to treat somebody's like leg wound on the phone with pictures. So it was great. You know, we were able to get everyone back in. Our medical students, we had medical students came back in, and that was so wonderful because that's one of the things I love is teaching, and having them back was such a wonderful, wonderful thing. So I'd say it was it was 2.5 years of just a slog that felt like I had, worked 6 years. I mean, it felt like it was a tremendous amount of time and an energy that was given in that short period of time that really leached a lot of energy from me. And not only me, but from everybody who works in healthcare or is involved with any of these service areas. It was really, really hard. It was the hardest thing I've ever done professionally, by a long shot, the hardest.
You've been listening to Monica Raymond, Ellen Nadinger, Helen Reed, Nathan Howell, and Natalie Herbert. The Life Became Very Blurry podcast is produced by me, Amanda Gustin, of the Vermont Historical Society, and Mary Wesley, Andy Kolovos, and Will Hamilton of Vermont Folklife. Oliver Purdue mixed this episode. Our theme music is the track Never Mind the Forecast from Burlington-based artist Expected Guest. Find more from Expected Guest on bandcamp.com. The interviews heard in the program were created as part of the Vermont Historical Society's Collecting COVID-19, A Vermont Story, an oral history project, and were conducted by me, Marcia Bosek, Mark Johnson, and Amber Wingerson. We had additional project support by Teresa Green and Tessa Brimblecombe. Funding for this work was provided by a grant from IMLS, the Institute of Museum and Library Services.